This lecture is going to be on causes of hyperkalemia. Hyperkalemia may be due to administration of potassium-containing fluids, decreased renal excretion of potassium, and shifting of potassium from the intracellular space to the extracellular space. Decreased renal excretion of potassium may be due to oliguric or anuric renal failure, hypoadrenocorticism, uroabdomen, or urinary tract obstruction. These disorders have very similar laboratory findings. For example, all of these diseases can have similar urine-specific gravities, increased concentrations of BUN, creatinine, phosphorus, and potassium, as well as decreased concentrations of sodium and chloride. So all of these results may be similar. Renal failure and hypoadrenocorticism may also have hypercalcemia. However, there may be some subtle differences to help distinguish the three disorders from one another. Renal failure may have evidence of renal protein loss, so a protein-losing nephropathy, or there may be evidence of tubular injury if you see casts in the urine. And cortisol deficiency with hypoadrenocorticism may cause the absence of a stress leukogram, hypoglycemia, and hypocholesterolemia. Potassium can shift from the extracellular space to the intracellular space with metabolic acidosis or rhabdomyolysis. The top figure, the top left figure, shows normal concentrations of hydrogen and potassium ions in the intracellular space and the extracellular space. The bottom figure shows a metabolic acidosis. The metabolic acidosis has caused increased concentrations of hydrogen ions in blood. So, in an attempt to normalize the blood pH, these hydrogen ions move from the extracellular fluid to the intracellular fluid. In doing so, potassium ions move from the intracellular fluid to the extracellular fluid in order to maintain electroneutrality. Hyperkalemia due to metabolic acidosis tends to be mild. Cell lysis causes the release of substances at higher concentrations inside of the cell into the extracellular fluid, so their concentrations increase in the extracellular fluid. Concurrently, those things that are at higher concentration outside of the cell shift into that dead space that is left by the lysed cell. The sodium to potassium ratio tends to be decreased with a select number of diseases listed here. This decreased sodium to potassium ratio is typically due to concurrent hyponatremia and hyperkalemia. But severe hyponatremia without hyperkalemia could also cause a low sodium to potassium ratio. Most of these diseases have already been discussed in this lecture, but diabetic ketoacidosis, or DKA, and secretory diarrhea have not been directly addressed. DKA is diabetes mellitus with an excessive production of ketoacids. With DKA, sodium is lost in the urine due to osmotic diuresis and ketonuria. Concurrent hyperkalemia occurs due to the ketoacidosis and the shifting of potassium from the intracellular space to the extracellular space. So we have sodium lost by the kidneys and potassium shifting. With secretory diarrhea, sodium is lost into the GI tract. Bicarbonate is also lost into the GI tract, and this causes a secretory metabolic acidosis. The hyperkalemia is therefore secondary to the acidosis. So again, we have sodium loss, this time it's into the GI tract, and potassium shifting due to an acidosis.